The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is the week where we ask questions and our really smart guests answer them. Welcome back to the podcast, Dr. Strominger.
Thank you very much. It's a real pleasure.
Well, I've heard nice things. Talked to some people who've listened, and they were very pleased with how well you taught about this stuff.
Well, that's nice to hear after, let's see, I'm celebrating my 40th medical school anniversary coming up. Hopefully I've gotten some things right by now.
I heard someone say once that it's an indication of how well someone understands something if they can help you understand it. And the more confusing their answer is, either it's just beyond anyone or their understanding is crystal clear. So way to go.
Yeah, well, what's that thing? Make it simple, stupid, or make it, yeah, exactly. Make it simple, stupid.
Well, let's dive right in. Ready for some questions?
Sure, let's go.
Okay, before we start, have you developed any disclosures we should talk about?
Unfortunately, no.
All right, we'll work on that. That'll be question number 6.
Thanks.
Question number 1. How do you suggest that we help people decide how long to keep kids out of school or daycare when the kids have conjunctivitis?
I knew this question was coming because you sent it to me. So what do? I go to Google AI and see what they said. Because it's one of those things. It's a terrible thing, right? You got your kid having conjunctivitis. And of course, you're worried more about viral conjunctivitis, although bacterial conjunctivitis can also be contagious. And you have parents screaming because they're out of work for a couple of days or what have you. The kids are miserable and you want to get the kids back to daycare or school as soon as you want. This is all practical. I mean, if you want to look at how long the virus can be contagious for, it can be contagious for a long time. But most of the time when you're contagious, you're also symptomatic, right? It's like if you have a runny nose and a cough, that's when you're contagious. Once the cough is done and maybe your runny nose is over, you're not as contagious anymore. So it's sort of the same thing with, I think, any conjunctivitis. Once you start seeing it turning the course where the eyes aren't as red anymore, the kid isn't as miserable, they may not be running a fever if it's associated with the virus, or the gunkiness is out of the eye if it's related to bacteria and their sore throat's better and their otitis is better, then that's safe to get them back to school. And depending upon the age, you always have to make sure that they're washing their hands, and you have to tell the teachers and everyone to be careful. So I think it's just more practical than anything else. Just, when they're getting better, that's when you send them back, right?
I'd have to say that's the number one reason why people call about conjunctivitis, though, is that the daycare says you can't bring them if they have pink eye unless they're on a medication, right? So that's the other pressure that comes is that, no matter the cause of the pink eye, as long as they're on medication, they can come back to infect everyone else.
Yeah. Well, we talked about before, if you have bacterial conjunctivitis and it's cooking, you put them on like moxifloxacin and it's better the next day, I think you can send them back. As long as you still get the drops in the eye before they go and then go home in bedtime or something like that. But the virus is a little different because that tends to last more of a couple of days and they're usually more miserable. So you might need to keep them out a little bit longer for that.
Very helpful. Question number 2. What special considerations should we make for contact lens wearers? Which eye findings should make them always take their contacts out? And how do you feel about extended wear contacts in general?
Well, I'm not sure what we're considering for contact lenses. I assume we're considering it in the context of conjunctivitis, right?
Right.
So, if we're considering in the context of conjunctivitis, you got to get the contact lenses out. The biggest problem with contact lenses is that if you have a small abrasion underneath your contact lens from the contact lens riding up and down or something getting caught in there, and then there's bacteria stuck in there, that's going to cause a corneal ulceration. So corneal ulcerations are really dangerous because that could perforate the eye and you can go blind. So the problem with contact lenses, it also creates a very moist environment that doesn't have a lot of oxygen underneath the contact lens. And so bacteria love that environment. So you have to basically get the contact lens out. I tell parents, and it's usually teenagers, because most of the time you don't see kids under age 12 wearing contacts.
Right.
You got to get the contact lens out, and you can't put it in for about 2 weeks, I say, or a week after your symptoms are better. So that's my advice.
Is there a point early in an illness where you would say you should err on the side of taking your contact lenses out as an illness may be waiting to declare itself?
Yeah, I mean, as soon as the eye's red and irritated, you got to get your contact lenses,
Okay.
right? I mean, there's other things that cause contact lens problems in kids. There's contact lens overwear, they get dryness. All those things make the situation worse, and it interrupts your epithelium on your cornea, and you're at higher risk for getting corneal ulcers. So I always recommend taking the contact lenses out. And anytime I see kids with contacts, I say, you know what? You need to carry around a pair of glasses, because if you're at school and you feel like something's in the eye, now this is not conjunctivitis we're talking about, but if you feel like something's in the eye and the contact lens is in there or rips or something like that, you got to know how to take your contact lenses out and put glasses on. You can't call home and have your mom come and take your contact lenses out for them. So a lot of times when we talk about contact lenses in kids, to parents, the big thing I ask them, are they responsible enough, do you think, to be able to take their contact lenses out at school and throw them away or put their glasses on? If they say yes, okay, then they're old enough. One thing about contact lenses is in my office, if I'm trying to examine a kid's eye and I can barely touch their eye without them screaming, they're not going to be able to put a contact lens in the eye, no matter what the parents wanted, right? So it's all a practical thing.
Very helpful. Question number 3, you talked about this some over the past couple of weeks, but
Right.
I'll sort of leave it open to you to interpret and expand on however you want. What red eye diagnoses are most commonly mistaken for conjunctivitis in children? And are there things that you think maybe we didn't talk about that we should be thinking about?
Yeah, well, I think we're talking more about the differential diagnosis of a red eye, right? Because as we talked about, not all red eye is conjunctivitis, and not all conjunctivitis is bacterial conjunctivitis. In terms of conjunctivitis, you have your viral, bacterial, allergical, and there's also chemical conjunctivitis. You get something splashed in the eye. So, you always worry about that. You can have a red eye from even minor trauma, getting hit in the eye. But if there's no history of trauma and the eye's been red for a while, I worry more about this is more an atypical atopic or allergic type of conjunctival inflammation. We talked about last time vernal conjunctivitis or atopic conjunctivitis. Those are the most common things that are sort of mistaken for the viral or bacterial conjunctivitis. The other things you also worry about is you can get some redness to the eye and inflammation and discomfort with anterior uveitis. So those are the kids who have juvenile idiopathic arthritis. It's not uncommon, but every once in a while you see a kid coming in who's had like this sort of redness and photophobia and discomfort in their eye. And you look in and they have anterior uveitis, and then you ask the appropriate questions and you find out they have arthritis conditions and diagnosis. The other thing is you can have something called scleritis. So scleritis is another autoimmune problem that can involve the conjunctiva and the sclera, and that's usually pretty painful. That goes along with kids who have other autoimmune type of diseases, inflammatory bowel diseases, lupus, things like that. I always tell the pediatrician, you got to take a good history, right? And I tell the ophthalmologist the same thing, because that sometimes helps make the diagnosis. Because if a patient has arthritis, then I'm looking for that. If a patient has inflammatory bowel disease, then I'm looking for that. If a patient has a known lupus, then I'm looking for that. So there's other causes of red eye than conjunctivitis, but those are the things that worry me the most. And of course, the things that really scare me are the ones that might involve the cornea, and therefore you'd have your vision loss. So if you have any red eye with vision loss, you have to be really concerned that it's not your typical conjunctivitis.
Very helpful. The next 2 questions are going to stray, I think, a little bit from conjunctivitis, it appears. So question number 4, what do you advise we tell parents about the watchful management of dacryostenosis. Is there any value in massage? Are there situations where they might benefit from topical antibiotics? When should they see an ophthalmologist? And what would be the risk if they continue to have dacryostenosis beyond the usual observation period?
So can I make a little plug for the AAP here? Because this is
Please
AH in
do.
Utah.
Yes.
So I'm on the section of ophthalmology for the AAP. And one thing I do every year, or hopefully I'll get to do it again, is to give a talk at the national conference on common diagnoses for the pediatrician, when to treat and when to refer. And we go over a lot of these things. So if you're really interested in things in more depth, come see my talk if I'm giving it next year. But this is one of the topics that comes up every year, and people stop me in the hallway and ask me these questions. And I guess you can call it dacryostenosis. I like to call it nasolacrimal duct obstructions, or the way I describe it.
Sure.
It's really pretty common. And you have to think about the natural history of it and what you have to do if it doesn't get treated properly. So the natural history of it is that the tears go down through the punctum, which is that little opening in the upper and lower lid, in through what we call the canalicular system, into the nasolacrimal sac, and then down a canal into the nose. And so for reasons we don't quite understand, a lot of times there's a little membrane or closure. It's called the valve of Hasner, which is in the nose where the tears go down. So every time you blink, the tears get pushed down into the nose, and that little membrane is not open. So what happens is that the tears back up. So a lot of times babies are born with tearing. And then as your normal flora in the eye develops over the first couple of months of life, some of that flora can go into the nasolacrimal sac and sits there and then gets sort of secondarily infected. And that's why you get this mucopurulent type of discharge. And a lot of times in the older babies, it's more in the morning, because overnight you're not blinking, so you're not pushing at least some of that material down into the nose. So the natural history of these things is that in 99% or so, it opens up by a year of age. And we think that's just because your facial structures grow and everything in your nose grows and expands out, and it just opens up, and it opens up that little membrane. So if I see a parent with this and the child just has some tearing, I say, you know what? Why don't we wait? Because 99% of the time, it's just going to open up by a year of age. They won't need to do anything. Sometimes you do get that mucopurulent discharge, which is a little bit concerning to the parents, not necessarily to me, but it's concerning more when all of a sudden you have inflammation and like a preseptal cellulitis almost along the eyelid. So it gets very inflamed. And in that case, I usually recommend using an antibiotic ointment to help settle things down. If a patient comes to me, I usually use an antibiotic steroid combination. I don't necessarily recommend that pediatricians use steroids with the complications of that. But if you feel comfortable, using a couple of days of antibiotic steroids usually clears things up for a couple of days. And a lot of times it comes back and it doesn't come back. So what to do after a year of age? So if it doesn't open up by a year of age, or it's just so miserable before, then the next step is to proceed with a nasolacrimal probing. And so what we do is we put the babies to sleep in the operating room, and we have the different size probes, and we put them down through the system into the nose, and that works about 90% of the time. If that doesn't work, then there's a couple options that a lot of the pediatric ophthalmologists do. Sometimes they have this thing called a balloon. They put it down there and blow it up in that ostium in the nose to try and open it that way. Sometimes I like to actually work with our pediatric ear, nose, and throat doctors, because if the probing doesn't work, sometimes it's sort of a balloon effect. You're trying to push this probe through this membrane. It just won't pop through. And so I work with the pediatric ear, nose, and throat doctors, and we combine it. They look up in the nose, and then a lot of times we do find the membrane, and then they just excise it and take tissue out, and that solves the problem.
Oh, interesting.
So that's sort of the way I manage it. Does massage work? It's hard to know whether massage works. I think the nice thing about massage is that it gets all that mucopurulent material that's in that sac out of there.
Mm-hmm.
I mean, it comes into the eyes and it's kind of a little disgusting looking. And I warn the parents, that's normal. Just kind of wipe it away. It's not a big deal. some people feel that if you massage and you sort of push down that fluid and it might pop open that membrane in the nose. So you can't necessarily argue about that. Usually by the time they come to me, the pediatrician's already recommended doing the massaging, and a lot of times they've already been on some intermittent antibiotics. So we sort of talk about the natural history of it and go from there. It's funny because I always tell the parents, and this happens probably once every couple of months, I schedule a little baby who's a year and a couple months. And because it takes me maybe 4 weeks or so to get the baby on the schedule and everything all set, I say, I've had cases where the day before the surgery, it opens up by itself, the tearing goes away. No problem, just call me and we won't do the procedure. It's funny how the anticipation of the procedure makes it go away.
So if you used antibiotics, how long would you use them? Since we expect this would probably be a recurrent issue.
Yeah, I use them for about a week to 10 days.
Okay.
And then it goes away, and then it sometimes comes back maybe 3 or 4 weeks later, and then you can use them again.
And if the anticipation of the procedure sometimes makes it go away, do you ever recommend sham appointments?
About that. What about that? And sometimes parents just don't want to do the procedure. And I'm like, well, that's fine. I don't know if this is part of the question, but anyway, so the things I always worry about, and there is an association with this, and I don't know what the association is or why there's an association. There is an association with some asymmetric refractive error occurring in that eye with the
Really?
set. Yeah. So I always check to make sure the eye's growing equally and they don't develop some laziness to the vision.
And is it the different refraction that's making it not correct, or is it causing the difference in refraction?
I don't think we know. It may be just an association. The eye's growing at a different rate on that side. So if the eye's growing at a different rate, when you look at how the light rays are focusing, they may not be focusing equally as the other eye.
Very helpful. All right. Last question. This sounds like we're going to deal with some trauma here. Once in training, I saw a child with eye discomfort, acute tearing, and corneal cloudiness who had acute glaucoma. I've worried ever since that we'd miss one of these when parents call in for telephone triage. Any thoughts? I mean, I think a common concern for all of us is that conjunctivitis is extremely common, and there are also some eye things that can be very serious. None of us want to miss them.
Right. Well, congenital glaucoma can cause a red eye and cause light sensitivity. It's not a common diagnosis. Even in my career, I haven't seen hundreds of these. But the thing to ask is, what's going on with the kid in terms of their other symptoms? Are they having trouble seeing? Cornea clouding is going to cause trouble seeing.
Mm-hmm.
If it's congenital glaucoma that's getting progressively worse, the reason why the cornea is getting cloudy is it's stretching. So there are these cells inside the inner layer of the cornea called the endothelium. And those are the cells that pump the fluid out of the cornea to keep it clear. So as the cornea stretches, it damages those endothelial cells, those pumps, and plus the high pressure, and they cannot function anymore, and the cornea becomes cloudy. And you also get something called ophthalmos. The cornea gets bigger. So in most cases of congenital glaucoma, at least the ones not in the newborns, you'll see the cornea getting larger. So there's going to be an asymmetry in terms of the eye size. The cornea is going to be cloudy, almost looks bluish. And sometimes the kids will be light sensitive and the eye can be red. So that's a concern. That's an emergency. I guess it depends upon how you handle your phone triage for conjunctivitis, right? We've talked about that.
Right.
The question you can always ask is, does the kid seem to be seeing okay? And what does the eye look like? Or nowadays we have cell phones, right? So just take a picture and send it in. If you see the cornea cloudy, then you have to be concerned. If you say, okay, well, I can't see the kid. They live 2 hours away. Oh, they have a pharmacy, start them on an antibiotic drop, and then see them the next day or the day after. A day of congenital glaucoma is probably not going to make a difference in terms of overall prognosis if you delay the treatment for a day or two.
And it seems that one of the common themes with a lot of these things you've talked about is that gathering more information and taking a look and collaborating, all those things are good.
Well, absolutely. That's all a medicine, right?
Right, absolutely. But also, I think in a busy practice, sometimes it's easy to forget that all those things are key to what we do.
Yeah, that is true. And I see kids every day who have been referred, and people sometimes just don't ask the right question. And if you ask the right question, a lot of times that gives you the answer right away.
And part of the reason we've been talking the last couple of weeks is so we can learn the right questions. Thanks for spending time with us.
That's right. My pleasure.
All right. Well, I hope we can talk again sometime. This has been very helpful and very pleasant chatting.
Well, thank you very much. I'd love to come back. We can talk about strabismus next time, maybe, or something like that.
Let's talk about strabismus.
Okay, great.
All right. Thanks so much for your time. And to our listeners, we'll be back with another topic next week. Thanks for listening. Tell your friends all about us. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who composed the theme music. See you next time.